My name is Dr. Riona Singh-Gansan, and I am a chemical pathology registrar at the National Health Laboratory Service and University of Cape Town, South Africa. And today I will be presenting a case report on adrenal venous sampling entitled Vein Expectations, Clarifying Confusion via the Laboratory After a Missed Right Turn. I will discuss the background, a brief case description using a clinical, pre-analytical, analytical, and post-analytical approach, a discussion, and what are the take-home messages. So adrenal venous sampling is an invasive diagnostic procedure used to distinguish unilateral from bilateral disease in primary aldosteronism, and this is the leading cause of secondary hypertension, accounting for about 10% of hypertension cases globally. It is often undiagnosed. It presents with a triad of hypertension, hypokalemia, and metabolic alkalosis. In unilateral disease, aldosterone to cortisol ratios are elevated on the affected side, whereas in bilateral disease, they are similar. AVS is technically challenging, especially right adrenal vein catheterization due to anatomical variation. The case is that of a 50-year-old male with drug-resistant hypertension on 6 antihypertensives and persistent hypokalemia. An assessment of Conn syndrome was made, however, CT imaging showed no abnormalities detected. AVS is an expensive and invasive test, and appropriate patient selection is essential. AVS should not be considered in patients who prefer lifelong medical treatment, if the risk of surgery outweighs the benefits, or if surgery is already indicated due to the size of the adenoma or other suspicious radiological features. Preparation of the patient is the responsibility of the endocrinologist and interventional radiology team. Once the procedure has been booked, a chemical pathology registrar should be made aware of the date to organize and plan laboratory support for the procedure. It is important to note that the following drugs need to be discontinued before the test. Of note, licorice should be stopped, as this inhibits 11-beta hydroxysteroid dehydrogenase, which can result in high cortisol levels, which mimics the effect of aldosterone. Any exogenous steroid use should be reviewed by the endocrinologist. Patients should be on an unrestricted sodium intake prior to admission. Hypokalemia should be excluded 2 to 3 days before the procedure, and if present, treated with potassium supplementation. It is the responsibility of the lab to ensure that forms and tubes are adequately labeled. This is Appendix 1 taken from the Standard Operating Procedure from the National Health Laboratory Service, and this ensures that each sample and the timing of each sample is adequately labeled. The procedure requires a multidisciplinary team. Performing AVS in the morning following overnight recumbency can avoid the confounding effect of changes in posture on aldosterone concentration and takes advantage of the effect of high early morning endogenous ACTH levels on aldosterone production. Baseline bloods of aldosterone, cortisol, and urea electrolytes should be taken. Synthetic ACTH can be administered 30 minutes prior to the procedure at a rate of 50 micrograms per hour. Sampling of the right adrenal vein, left adrenal vein, and inferior vena cava is then performed. Samples are taken down to the lab, registered, run, results transmitted, and then reviewed. Important to note that if the radiologist cannot be confident that both adrenal veins were successfully sampled, the AVS data is not clinically useful. Post-analytically, these are some of the calculations used in the procedure. The aldosterone-cortisol ratio, the selectivity index, which is the cortisol on a specific side divided by the cortisol in the peripheral IVC, and a cutoff of greater than or including 2 is used in unstimulated conditions, or a cutoff of greater than or including 3 used with ACTH stimulation. The lateralization index is the ACR on the dominant side divided by the ACR of the non-dominant side, with the cutoff being greater than or including 2 in unstimulated conditions or greater than or including 4 when ACTH stimulation is used. The contralateral suppression index can also be calculated. These were the results from the initial AVS of our index patient, and you can see that the selectivity index was less than 3 in the right adrenal vein, and this portrays an unsuccessful cannulation. The remaining results can therefore not be interpreted to establish lateralization. There was a study performed by Rossi et al., which mentioned that if results are equivocal, it is crucial to estimate other predictors to determine the likelihood of an aldosterone-producing adenoma and the probability that the patient would benefit if adrenalectomy were performed. Because APAs are mostly benign, many patients can be controlled medically, and hence false negatives are less serious than false positives, and it is appropriate that diagnostic thresholds be generally high. In addition, we also perform serial dilutions of aldosterone as the original results were greater than the measuring range, and we discovered a non-linear dilution pattern, and we attributed this to interference, with the most likely interferent being contrast. 2 years later, the patient was finally optimized after multiple admissions for sepsis, and AVS was performed again, and the results of this sampling suggested successful catheterization of both the left and right adrenal vein, as evidenced by a selectivity index of greater than and including 3 on both sides post-stimulation. The right adrenal gland appeared to be the dominant gland, and lateralization was suggested by the lateralization index of greater than and including 2 pre-stimulation. Unfortunately, after multiple surgical consultations, the surgical team did not consider the patient an ideal candidate for an adrenalectomy, and he is being managed medically. So this case illustrates the limitations of AVS and the necessary collaboration of chemical pathologists, clinicians, and interventional radiologists. Despite a 95.6% bilateral success rate in expert centers, right adrenal vein cannulation remains difficult, and this is because it is often harder to locate and successfully cannulate than the left. It is usually smaller and shorter, it has an angulated path, and it usually empties into the IVC rather than the renal vein. Synthetic ACTH stimulation may improve success fourfold, and it is recommended for the following reasons: to minimize stress-induced fluctuations in aldosterone secretion during non-simultaneous AVS, to maximize the gradient in cortisol from the adrenal vein to the IVC and thus confirm successful sampling of the adrenal vein, and to maximize the secretion of aldosterone from an aldosterone-producing adenoma. It is suggested that adrenal CT be the initial test to distinguish between APA and bilateral hyperplasia. A meta-analysis in 2009 showed only a 62.2% concordance between imaging and adrenal venous sampling. If CT or MRI alone had been used to determine subtype, 14.6% of patients would have inappropriately undergone unilateral adrenalectomy, which would not have been curative. 19.1% would have been offered medical therapy instead of a curative adrenalectomy, and 3.9% would have undergone adrenalectomy on the wrong side. These observations highlight the importance of performing AVS in most patients to distinguish between unilateral and bilateral adrenal aldosterone hypersecretion. So the take-home message is that the laboratory plays a critical role in providing suitable testing with appropriate interpretive information for specific methods used. AVS is considered the gold standard to subtype PA. However, appropriate training programs and certification of radiologists proficient in AVS is required. While unilateral production can be effectively treated medically, patients who undergo AVS-directed adrenalectomy have a high rate of biochemical cure, high rate of resolution of hypokalemia, potential for hypertension cure, lower hypertensive medication need, less medication side effects, and overall a better quality of life. I would like to acknowledge the following individuals, and these are my references. Thank you.